Right, after that glitch, thank you very much, everyone. In the next 15 minutes or so, I'll probably run over as well. Apologies for that. I'm going to try to talk to you about the role of TCD in death by neurological criteria, so in brain death. I have no financial disclosure. I'm a pediatric ICU consultant, and all the images you're going to see are from my personal files. Hopefully, by the end of the talk, we will have touched upon physiopathology, waveforms, evidence for TCD in brain death, limits, and the big question, actually, what is the role, if any, for TCD in diagnosing death by neurological criteria? So first of all, some definitions. Catastrophic neurological injury is defined by NICE guidelines in the UK as the absence of one or more cranial nerve reflexes and a Glasgow Coma score of 4 or less, which is not explained by sedation. While brain death, also in the UK, is the state when a person is on an artificial life support machine and no longer has any brain functions. That means that they will not regain consciousness or be able to breathe without support. On the other side, the hemodynamics of it all, cerebral circulatory arrest means a complete cessation of cerebral blood flow due to critically elevated ICP, which exceeds the systolic blood pressure, resulting in not forward flow in the cerebrum. Now, in terms of the TCD patterns and flows associated with this, you've got 3 main ones. So the oscillatory to and fro, which means that you've got forward flow and retrograde flow within a cardiac cycle, forward flow in systole, retrograde in diastole, short systolic spikes without any flow in diastole, and that short systolic spike needs to be less than 200 milliseconds and less than 50 centimeters per second of velocity, and absence of flow intracranially, which needs to be documented extracranially and needs also to have documentation of previous existing flow. This landmark study by Ducoc, published in 1998, looked at 130 cases in patients aged 2 to 88 years of age, and they identified the patterns of flow that we've discussed, so oscillating in about 73% of cases, systolic spikes in about 25%, and absence in about 4% of cases. And they had an outstanding accuracy. So sensitivity was 95%, specificity 100%. And more importantly, they totally correlated with EEG and angio results, and they were useful even for patients under sedation. So this study included 13 pediatric patients aged 2 to 15 years of age, and the patterns that were shown by the pediatric cases were identical to the ones seen in the adults. Also in 1998, the World Federation of Neurology established criteria for brain death by TCD, and they said that you first of all need to get rid of all your confounders. You need to have a cause for your coma sufficient for permanent brain function loss. You need to exclude everything like intoxications or other things that might confound the diagnosis, and the TCD needs to have certain technical accomplishments. So you need to have both intra and extracranial findings. They need to be documented bilaterally, and you need to have at least 2 exams more than 30 minutes apart. The findings are what we discussed already: oscillating flow, systolic spikes, and extracranial conformation. And you need to look at both the anterior and posterior circulation. Importantly, they also stated that absence of signal alone is unreliable and may be a transmission issue. And therefore, in order to document circulatory arrest, you need to have disappearance of flow. So you must have presence of flow first and then disappearance of flow afterwards, with extracranial confirmation of this. In 2016, Chang et al. Published a systematic review and a meta-analysis. This comprised 22 studies of and had more than 1,700 patients in them. The patterns were, again, systolic spikes, oscillating flow or reverberating flow, and absence of diastolic flow. The conclusion was that TCD is a reliable ancillary test for brain death. But where does that leave us? It actually limits us because they purposefully excluded pediatric-only studies. And from there on out, it becomes even more muddy. So in terms of legal acceptance, TCD is legally accepted as a confirmatory test for brain death in some European countries. Some of them mandate it, so they have as mandatory within their protocols, such as Germany. And also accepted in Latin American countries, but all guidelines so far are specifically limited to adults, and they mentioned that they should not be used in children. In the UK, the criteria for death by neurological criteria have been updated in January 2025, and they specifically state that no ancillary tests are allowed. We cannot get in there. So the same thing happens for the American Association of Neurologists. In 2023, the guidelines were published in concordance with other societies, including the Society for Critical Care Medicine, specifically stating TCD should only be used in adults and it's not accepted in children. So the bottom line is, in pediatrics, you cannot use TCD as a diagnostic test for brain death. And a very short mention of the World Brain Death Project, a massive, mammoth piece of work published in JAMA in 2020, which states TCD should not be used as a confirmatory test for brain death in pediatric patients. So why is this? Why do we have so many things that say you shouldn't? So despite TCD's utility, there are several technical limitations that led to this conservative approach. And these limitations have been identified really wonderfully in this article that was published this year by Reynolds and her colleagues on technical consideration for TCD evaluation of cerebral circulatory arrest. So there are several confounders which can lead to false negative results, and these are open fontanelles in which persistent diastolic flow can be seen in clinically brain-dead infants due to their open fontanelles. The same for craniectomies, burr holes or EVD that can create false negatives due to pressure decompression. And there is a situation of anoxic brain injury in which patients may lose brainstem reflexes but maintain cerebral blood flow. Mechanical circulatory support, as Brian was mentioning before, where you have no non-pulsatile waveforms and classic patterns will not be seen. And then you have false positives, situations like severe aortic insufficiency or hypertrophic cardiomyopathy that can mimic circulatory arrest patterns, especially oscillating flow. And on top of that, the thing that is mostly mentioned in every single study and every single article out there about TCD and brain death, we have no systematic pediatric validation studies. And that is our problem. So we'll go through a few cases. This is a 1-month-old little girl that was admitted to my unit with a traumatic brain injury, which is visible on her CT. And immediately as she arrived, we performed TCD, and you can see that the TCDs are sort of mirror imaged, and that's because we insunated the left MCA through the right side. So, but you can see that both sides show oscillating patterns, so forward flow in systole, reverse flow in diastole. And I was sure that this was it. And when I rescanned her on about 5 days later, this was the pattern that we saw. And you can see that the reverse diastolic flow has completely corrected itself. You have forward flow in systole, you have forward flow in diastole, albeit going back all the way to the baseline, and having a high resistance pattern. So what does this mean? So this patient wasn't brain dead and actually made it out of PICU and was not on any respiratory support or cardiac support. However, 4 months later, this was her CT. And the CT shows severe encephalomalacia with complete loss of supratentorial structures, loss of thalami, loss of basal ganglia, and partial loss of cerebellum. And unfortunately, she passed away a year later, so the second CT is a year later for her. And whilst this patient wasn't brain dead, as per clinical criteria, she unfortunately suffered a important enough hypoxic injury that led to her brain not surviving, or parts of her brain not surviving. What about shunts? Shunts are an important caveat that was identified in Reynolds' article. So this is a patient that had a large hemangioendothelioma. She was 5 days of age, and she arrived in PICU with mild cardiac failure and decompensation. She was intubated and ventilated. And this is the pattern that we saw in her MCAs. And you can see that initially we have really just systolic forward flow and then intermittent, very, very small retrograde flow in diastole. And this, the day afterwards, so these are on the 17th, these are on the 18th of February last year, this reversed component accentuates. This was her hemangioendothelioma, and this was the flow pattern in that. There was already reversed flow in her renal arteries, and she had a large PDA as well. And the left-right shunt was augmented as the days go by. And then this all corrected when the surgeons decided to intervene surgically. We decided that this is no longer manageable conservatorily. Another issue is with TCDs and severe brain injuries. Sometimes the brain injury is so severe that you don't see any flow initially, even on your first examination. So what do you do with that? In this particular patient, this was an adolescent with a road traffic accident. We tried to increase the systolic blood pressure to see if there's anything there. The only thing we got was sharp systolic spikes with very, very low velocities. And we confirmed that extracranially. You can see that the common carotid bilaterally has nice flow despite being with a slow retrograde, short retrograde component in the diastole, but the ICA had only sharp systolic spikes, small systolic spikes. The same in another patient. I always like to look at not just the common carotid artery and internal carotid artery, but I also like to see the external carotid as well. So you can see in this patient, again with traumatic brain injury, she had the same type of flows virtually in her common carotid artery and external carotid artery, but her ICA showed really only sharp systolic spikes, short systolic spikes. This is a patient that unfortunately passed away quite recently in our ICU. He was 10-month-old with biliary atresia and failed Kasai and was in ICU for a month awaiting transplantation. At his arrival, he initially was encephalopathic, sleepy and irritable. And we admitted him for monitoring and for management. And unfortunately, a month later, because there was no available donors for him, he suffered ischemic hepatitis and clinical deterioration. He was intubated and ventilated on vasopressor support, on CKRT for rising ammonia. And as we performed the TCDs on that day, his PIs were extremely high, and we actually noticed that he was seizing focally, which didn't stop until we induced barbiturate coma. And unfortunately, later during that day, so just a couple of hours later, he started showing reversed component in diastole, and then by 7 p.m. he had a full retrograde flow in diastole. And at this point, the question was, what are we doing? Because we were still contemplating the idea that he might get a transplant, and the parents were very insistent that they would like to donate. So we decided to do a CT head, and unfortunately the CT head confirmed what we had seen. I'm going to try to speed this up a little bit, and you can see the severity. There's a global ischemic injury seen throughout all his structures, and we stopped intensive care measures because of that. So I think the gap, one of the most important gaps that we have is understanding exactly on this trajectory of raised velocities, raised PI with a lower end diastole, with starting to see reversed flow in diastole and then systolic spikes. Which one of these is the last one that we can reverse? Which one of these types of curves is the last one that we can reverse and still have meaningful neurological recovery? I think that's a really important question to answer. And the validation would be fantastic if we could achieve it. Validation would be amazing because it would mean that we'd have a non-invasive tool that it's much more common in all parts of the world than nuclear medicine or angiography. And the thing that is missing is actually standardized protocols and, as identified by everybody else, validation studies. So ultrasound is operator dependent, and that's one of the things that people keep leveraging at it. And I'm always amazed by how people just stop thinking at that and don't recognize that actually medicine is operator dependent. Everything that we do at the bedside depends on us understanding what we do and knowing how to do it well. So TCD is nothing but that, and ultrasound is nothing but that. We need to be good at what we do and understand what we do at the bedside. So these are my 5 rules for transcranial Dopplers in a patient with severe traumatic brain injury or severe brain injury per se. The fact that you've got no signal doesn't mean that you have no flow. Try to do your first exam as soon as possible to establish the presence of windows. If you've got forward flow, both in systole and diastole, you definitely don't have any circulatory arrest. Try to optimize hemodynamics as much as possible. You can salvage that brain. Insonate both the anterior and the posterior circulation. If you have no flow, confirm extracranially. Confirm not just with carotids, but you can confirm with vertebrals extracranially as well. Repeat your exams. I think the 30 minutes apart exam was identified also by the article published this year as having no reason. There's no reason why we would say that we have 30 minutes apart, except maybe that's what we have from the clinical examination in brain death. And I think that examining, just like Virginie mentioned and Mariana mentioned, trends are much more important than just single examinations per se. Absence of flow or flow pattern suggestive of circulatory arrest, it's just that, it's circulatory arrest. It doesn't necessarily mean brain death. So TCD, I think, can support a diagnosis, but it needs to be appropriately used and interpreted with caution in things like surgical interventions, cardiac disease, mechanical circulatory support. But I think it has its appropriate role in supporting the diagnosis. And I don't know why we would insist on it being a standalone thing to hang our hat on when we need to integrate, just like with POCUS anything, we need to integrate it into the clinical examination, into what we already know about the patient. So what we need is to train, to standardize, to log cases, to assure that we have quality of what we do, and integrate the exam. And this is how I think TCD can become actionable. Thank you very much.